All right, so good evening and welcome to our Learn and Share conference call. I'm Russ Derry, the Director of Education for Epilepsy Foundation of Michigan, and I'll be moderating this discussion. The topic for today is brain injury and epilepsy, and we're pleased to have as our speaker Dr. Yanny Phillips, who is an epileptologist at Bronson Neuroscience Center. Dr. Phillips, could you briefly introduce yourself and talk a little bit about your clinical and research interests and describe your experience with this topic?
Sure. Thank you so much for having me, Russ, and everybody. I'm a neuroscientist by training and did a lot of pharmacologic and physiologic studies back in the day when I was in school that related to brain development and connectivity. For the past decade, though, my focus has been mostly clinical. There's a clinical trial that our center is participating in right now, but a majority of my time is just spent taking care of patients with seizures and other neurologic diseases.
Okay, great. So for the purposes of this call, we'll be discussing acquired brain injuries. This does not include injuries that are genetic, congenital, degenerative, or induced by birth trauma. So acquired brain injury can be broken down into non-traumatic and traumatic. Can you explain the difference between these types and give some additional sub-classifications within each type and just provide some common examples of injury causes?
Acquired brain injury results from any damage or injury to the brain that is not present at birth. So this is not congenital, this is not genetic, as you mentioned. Brain damage occurs when the neurons or brain cells are destroyed, which can be caused by either internal or external mechanisms. So traumatic brain injury, TBI, I'm sure most people are familiar with this term. This results from an external physical trauma or quite simply just a blow to the head. This can be caused by gunshot wounds to the head, from falling, motor vehicle accidents. Actually, in my seizure clinic last week, I saw a follow-up patient who got kicked in the head by her horse, and then another patient the same week who developed seizures during his military tour of Iraq when he suffered a blast injury when I think there was a nearby bomb that detonated. So other causes can be from firearms, sports, physical violence. Non-traumatic brain injury, these causes are internal. That is, it's something that happens inside the body. So stroke would be the leading cause of that. Other causes include brain tumors, bleeding from the brain, such as from ruptured cerebral aneurysms, multiple sclerosis, hypoxia. So when the brain is deprived of oxygen, such as something that we commonly see here, cardiac arrest patients who suffered heart attack, drownings. I'm forgetting a big one that I thought okay. And infections like meningoencephalitis, or more localized brain lesions like an abscess. So brain injury, whether it's traumatic or not, can be subdivided into, there are many different classifications. One would be severity, whether it's mild, moderate, or severe. They can be classified based on the pathoanatomy too. Is this blood related? They can be classified based on etiology. So there's many different classifications. I'm not sure.
Right. No, that gives a real broad overview of just how complex it is and how many different ways that people can acquire a brain injury. So can you talk a bit about the epidemiology of epilepsy and brain injury?
Brain injury is very, very common. So the epidemiology of head injury itself, again, it's very common. This is one of the most commonly identified reasons that people go on to develop epilepsy. And the incidence of epilepsy development, this varies based on different types of, so we just mentioned a variety of different external and internal causes for brain injury, and epidemiology varies based on which types. So anyway, I'll discuss the epidemiologic data for the leading brain injury types separately. So for TBI, roughly about 5 to 7% of TBI hospitalizations result in at least one seizure occurrence, but this would correlate with the severity of injury. So a mild head trauma might not definitely result in a seizure, whereas somebody that has had a more extensive injury would be more likely to have experience a seizure. So injuries that involve bleeding, for example, or where the dura is penetrated, so involving cortex, would increase this risk. Let me see, kind of lost my train of thought there. So I looked at some data looking at the Centers for Disease Control and Prevention, the CDC data, and they found that going back to 2010, TBIs resulted in approximately 2.5 million ED visits and hospitalizations in the U.S. This is because of direct injury or other related injuries. And then as the years progress, as they continue to trend that data, there seems to just be a rise in this number. The leading cause of TBI would be falls. This is disproportionately affecting children and elderly. Other leading causes include a blow to the head, either like being conked in the head with an object striking the head, or vice versa, or during, such as during a car accident, for example. Anyway, other causes include violence, intentional self-harm, and the incidence of post-traumatic seizures. So these are seizures that result from said traumatic brain injury. This kind of varies too based on demographics. It's reported to be as low as 4% in some populations, but as high as up to 50%. Having a post-traumatic seizure doesn't definitely mean that this person will go on to have epilepsy in the future, but there is a higher risk. So typically, the onset of that would be, well, actually, depending on what type of injury. Actually, you know, I think we're going to touch on early and late seizures later on, so maybe I should save this discussion.
Sure. And what about like stroke, for example, as being one of the leading causes of non-traumatic?
And stroke is also very, very common. Yeah, so in the U.S., about every 45 seconds, somebody suffers a stroke, and it's purported to be accountable for 1 out of every death in the U.S. So strokes are, actually I can talk a little bit more basic stroke. So strokes are divided into ischemic stroke, so not bleeding, and that's about 87% of all strokes, according to, I forget which research I was looking at. And then hemorrhagic strokes, or strokes that are bleeding strokes, there's blood in the brain. That's a much smaller percentage, so that's 13% of all strokes. And then there's further categorization of ischemic strokes into embolic, or whether they are small vessel in nature, so the so-called lacuna strokes. And hemorrhagic strokes can be further divided into whether it's intracranial hemorrhage or whether they're subarachnoid hemorrhage. Anyway, so looking at the development of epilepsy in stroke patients, epilepsy was found in 17% of patients after a stroke. The occurrence of epilepsy is 14% in ischemic stroke, 15% in intracranial hemorrhagic strokes, but 35% in subarachnoid hemorrhage. This makes sense because subarachnoid blood gathers over the cortex, irritating this area, and this is where seizures are generated from.
Okay.
So these are high numbers.
Right. All right. Now, and presumably, just in general, the risk of developing epilepsy increases, with the more severe the injury, the higher the risk for epilepsy. Is that pretty safe
Right,
assumption.
and then the location too.
Right. Okay. So, and does that mean like things affecting the cortex as opposed to deeper injuries, or I guess how does location impact the epilepsy risk?
Yeah. So injuries. So hemorrhagic stroke, for example, usually in subcortical structures. So for hypertensive bleeds, for example, it rarely leads to any development of seizures, whereas bleeding or strokes in the cortex, in lobar strokes or subarachnoid hemorrhagic strokes, these are high risk for developing seizures.
Okay. So does a concussion or multiple concussions increase one's risk of developing epilepsy?
Absolutely. So as we just discussed, a concussion is a blow to the head. So injury to the head, depending on the severity, can result in post-traumatic seizure. And the likelihood of developing post-traumatic epilepsy later on is higher the greater severity of this trauma. Repeated concussions, so I think we're going to talk about chronic traumatic encephalopathy later on as well, but this is a degenerative brain disease that's caused by repeated head trauma, such as repeated concussions. And while I don't know that definitely this entity in itself there has been a greater report of seizure onset, and actually I don't really have that data, but it would make sense that more concussions can lead to a greater degree of injury and subsequently more seizures or higher risk of seizures. Right.
And since we're talking about that, we were going to talk about it later, but I can address that now since we're discussing it. But presumably chronic traumatic encephalopathy, which again has become kind of a hot topic with its increased prevalence in the NFL, but presumably that would increase the risk, but it's probably hard to tell because, isn't it, chronic traumatic encephalopathy can only be, definitively diagnosed post-mortem, right?
Post-mortem, right.
Yeah, so probably hard, epidemiologically challenging to figure out, whether, what that leads to, what other conditions that leads to.
Yeah, it's unclear whether or not chronic traumatic encephalopathy leads to a greater risk of epilepsy, but there definitely is some evidence looking at patients who are who with epilepsy. I think there was one report looking at younger adults, and they found that up to 10% of those individuals did have early signs of chronic traumatic encephalopathy in their brain tissue. So it may be the other way around. So
okay. That's presumably from repeated falls from seizures?
Right. I think that was the hypothesis, but it's unclear.
Yeah. Okay. So brain injury is often associated with one or more seizures in the first few hours or days after the injury, and those seizures are generally considered provoked and not epilepsy. Some people, however, will go on to have spontaneous or unprovoked seizures later in life, and that can be from a few weeks later to many years later, and that is considered epilepsy. So can you talk about the time frames that determine whether a seizure following a brain injury is provoked or unprovoked, and how the diagnosis of epilepsy is eventually made?
Mm-hmm. So generally, seizures after brain injury appear early, within a week of the insult, or could be later. Early seizures should be, so actually there's different categorizations of this too. There's sub-classifications for early seizure. These are less than a week after the initial insult, and then immediate seizures, which is defined as those occurring within minutes to up to 24 hours after the injury. The mechanisms for why seizures arise differs, and that's why the different classification. late seizures occur greater than a week after the injury.
Okay, and with late seizures, those are those then considered unprovoked seizures, and would then the same standard diagnostic criteria for epilepsy apply? So that if you have if you have one unprovoked seizure plus additional evidence to suggest you're at risk for subsequent seizures, or if you have two unprovoked seizures separated by greater than 24 hours, are those the same kind of diagnostic criteria when brain injury is involved, or is there a different diagnostic criteria?
It is. So early seizures, they consider acute symptomatic seizures when they're occurring at the time of the brain insult, and these are thought, like you said, to be provoked seizures because they are felt to represent a direct effect of the head trauma. Whereas seizures that occur later on, after the immediate effects of the head trauma have passed, late seizures may indicate a permanent change to the brain structure and therefore imply epilepsy. So I think I'm sorry if I'm jumping ahead to other
no, that's fine.
areas. I think you might have a section on that later on, but initially, after a brain trauma, there is a initial response to the injury itself, and so that's felt to be more of an immediate response, and this is a provoked response. Typically, while development to epilepsy can occur, it doesn't imply that this person will definitely go on to have epilepsy. Whereas later on, the longer it is after a patient has onset of seizure is from the initial onset, the latency for development of late seizures, the more likely that this will be permanent.
Okay, and is there a for those who among those who have late seizures, are they more likely to occur in the first few weeks or months after the injury, or are they more likely to occur many years later, or is it kind of a mixed bag?
It is a mixed bag, but the peak onset of late onset seizures would be 30 days, but this can occur years after the injury.
Right. Okay. So can you describe in lay terms some of the possible mechanisms that can lead from a brain injury then to a provoked seizure and then eventually to epilepsy?
Absolutely. So I'll try my best. Just as a disclaimer, I just want to point out I'm not a pathologist. I'm sure that pathologists can provide much more depth to the understanding of these possible mechanisms. So seizures and epilepsy are common sequelae from brain injury, such as what we just talked about, traumatic brain injury, stroke, and brain infections. TBI, for example, this results in damage to neurons on the surface of the brain, and over time, this damage results in the potential for abnormal electrical circuitry, resulting in seizure activity. So this happens via different possible mechanisms. There could be direct damage, so for example, if it's a gunshot wound or if it's a bomb blast, there could be bone fragments, arterial bleeding can cause high pressure to the brain, resulting in further damage. And furthermore, during concussions, or there can be diffuse axonal injury, so the twisting and stretching forces in the brain tissue can result in shearing damage. And this trauma over time can result in swelling of brain tissue. So kind of like bruising, like you got punched in the arm, for example. So this results in high pressure to brain tissue and damage, more neuronal damage. The damage over the brain area over time can change the chemical composition and the way that the wiring patterns are. producing abnormal electrical power to produce these seizures. Epileptogenesis is defined as the development of spontaneously of making brain cells that were not previously epileptogenic, were not previously causing seizures, now turning them, changing their chemistry into capable of generating spontaneous seizures. These initial changes can then lead to a cascade of other factors, then resulting in epileptogenesis. I don't think the exact process, epileptogenic process, is clearly understood.
Right.
Right. So as far as I understand it, the initial changes after the injury, this is felt to be due to alterations in the blood-brain barrier, excessive release of excitatory neurotransmitters such as glutamate, and then later on, the latency to development of epilepsy is variable from weeks to months to years even. But the late onset seizures are thought to indicate permanent damage that has resulted from these neuronal changes, from the increased excitotoxicity and the aberrant rewiring of systems.
Mm-hmm. Yeah, so it's complicated. In short, it's
very complicated.
So yeah, it sounds like there are physical forces involved, there are biochemical changes involved, cellular changes, some of which are immediate and some of which are over a long period of time.
And it's all leading to this greater hyperexcitability.
Right.
And then epileptogenesis.
Yeah. So that is kind of one of the holy grails in epilepsy research, is to figure out how to stop the process of epileptogenesis after an identified brain injury, and thus prevent or lessen the severity of epilepsy. What's the current state of this research? I know there's been some looking into current anti-seizure medications to see if they actually have anti-epileptogenesis properties, and that, from what I've gathered, there's not been much promising findings in that regard. But do you know anything in terms of what's kind of currently going on in research in that area, or what's on the horizon?
There's no treatment, to my knowledge, that has been shown to prevent development of epilepsy from brain injury.
Right.
There's active research looking at factors that can contribute to epileptogenesis, in hopes of finding therapeutic targets to stop this development of unprovoked seizures after this initial brain injury insult. You just mentioned there was previous research looking at different anti-epileptic medications prophylactically in patients immediately after the head injury, prior to any development of late seizures, to see if this would prevent eventual development of epilepsy. Unfortunately, over the long term, prevention of epilepsy has not been proven, and prophylactic anti-epileptic medication usage is no longer indicated.
Okay, so given that, what are the current best practices in risk management and management of seizures in those initial days following the most common types of brain injury? Are there kind of clinical guidelines on what should be done, or is it still unclear on what the effective strategies are? So the treatment with anti-epileptic medications is indicated immediately after the initial injury, because the thought is to prevent further trauma from having seizures. Further seizures occurring can cause excitotoxicity and hypoxia, and release of excitatory neurotransmitters, and thereby increasing metabolic demand and more pressure to the brain. So it's recommended that as soon as
possible after the traumatic brain injury to start treatment with anti-epileptic drugs. However, it's not indicated for late seizure or for prevention of late seizures. So after treatment with anti-epileptic drugs, most studies would suggest like a week up to some studies suggest longer, up to a month, but patients aren't kept on anti-epileptic drugs long term unless they've suffered a clinical late seizure, thereby indicating onset of epilepsy.
Okay. So brain injuries can be classified as focal, diffuse, or sometimes a combination of both. Can you describe what those terms mean and how they relate to whether a person's subsequent epilepsy is generalized, focal, or multifocal?
Focal refers to localized injury over a specific area of the brain, whereas diffuse refers to widespread injury. So a stroke may cause brain injury to a focal area where the certain vascular territory was affected, while something like a brain infection like meningitis may be more widespread. A single brain injury, though, can cause both focal and diffuse effects downstream. So, for example, like a stroke in the left MCA territory, for example, middle cerebral artery territory, for example, can cause primary injury to that area, but then later on, if this is a very big stroke, a malignant stroke can lead to other injuries, secondary injuries, such as cerebral edema or even herniation and death. So the same insult, the same brain injury can lead to both focal and diffuse symptoms.
Okay, and then does that, track to, like if you have diffuse injuries, does that mean you're more likely to develop generalized epilepsy? And if you have focal injury, you're more likely to develop focal epilepsy, or is it not that clear-cut?
Most brain injury results in focal epilepsy,
okay.
Focal seizures. Typically, generalized epilepsy, something that is diagnosed more in childhood.
Mm-hmm. Right. Okay. And what are some of the key brain injury-related factors that affect epilepsy prognosis?
I think the most important factor goes back to the extent and the location of the injury.
Mm-hmm.
Post-traumatic seizures are more likely to occur in more severe injuries, in certain types of injuries. So patients with injuries, again, to the cortex or more brain structures would more likely develop seizures and epilepsy in the future. However, that risk, though, becomes progressively lower as time passes after the injury.
Okay. Makes sense. So can you give a few examples of how brain injury-related factors might influence epilepsy treatment decisions?
How do you mean by that?
So, let's say there's one penetrating head injury, for example, or brain injury, and does that, is someone with that type of injury less likely to be able to eventually have epilepsy surgery, or or is a stroke less amenable to surgery or neuromodulation or other types of treatments? I guess, does the nature of the injury eliminate or indicate that certain treatments might be more effective for epilepsy?
Sure. So absolutely. So if the injury is very widespread and it's difficult to localize, then treatment, epilepsy surgery, for example, if there's no target, there's no area that you can't sacrifice too much brain. It has to be localized well, and it has to be an area of the brain that risk versus benefits upon resection or ablation. It can't cause more symptoms that going into it. So if this is a extensive stroke causing like a hemispheric insult, this would be very unlikely to be a surgical candidate. But neuromodulation, like vagal nerve stimulators, possibly even deep brain stimulators, can be helpful there. Actually, I didn't mention neuropace responsive neurostimulation.
Right.
Yeah, the size and the extent and where this location is. If this is a gunshot wound penetrating an area of the brain that is not amenable for resection, it's too deep, or it's in areas of the brain that are vital, that also limits the extent to which surgery can be offered. Actually, won't be offered, probably. And then, and also with starting anti-epileptic drug treatment in patients who, so typically after a provoked seizure, acute symptomatic seizure, there's no need to start a patient on anti-epileptic drugs, just like the regular population without traumatic brain injury. The same holds true for those that have suffered head injury. Now, if they have an injury, so epilepsy is defined as a person that has a predisposition for having more seizures. And operationally, this is someone that has had more than one unprovoked seizure, or in this case, late seizure that's greater than a week out after the initial injury, and it's now not thought to be provoked. And if this is an injury, if this is a patient with a head injury that is felt to be more likely to produce recurrent seizures in the future, I wouldn't wait for a second seizure to happen before starting them on anti-epileptic drugs. So absolutely the type of injury would influence my decision making into what pathway to for their next recommendations for treatment.
Sure. Now, like with brain tumors, for example, often the person may have surgery to remove the brain tumor and then may develop epilepsy later, either because of the delayed effect of the brain tumor or because of the scar tissue from removing the brain tumor. Is that a situation where that person, if they have had surgery already to develop or to remove the brain tumor and then develop epilepsy, and could they potentially be a surgical candidate in the future because even though they've already had surgery?
I think it depends on how much where the brain tumor is, how much
Sure.
scar tissue there is. I actually did have a patient who had a brain tumor at, I think it was a DNET, this embryonic, so it's a childhood tumor that she had, and had resection of that later on, prior to being in my care, had subsequent brain surgery for epilepsy surgery later on, I think probably when she was an adult.
Okay.
So I don't know that this is definitely not doable, but again, it depends on the extent of scar tissue. But even if they can't be a resection or ablation candidate, potentially neuropace responsive stimulation, vagal nerve stimulator, and deep brain stimulation. So neurostimulation can be offered.
Sure. Okay. So we've talked about how brain injury can lead to epilepsy, but let's briefly talk about how epilepsy can increase the risk of brain injury. Can you talk about some of the different ways in which epilepsy can lead to brain injury and how common it is for this to happen, and then what people can do to reduce those risks?
So one thing the first thing that jumped into my head was falls. So patients with seizures, especially generalized tonic-clonic seizures or atonic seizures, the so-called drop seizures, are classic examples of seizure types that can result in falls and subsequent injury. During seizures, a variety of other injuries can occur. including tongue trauma, head trauma from repeatedly striking their head, shoulder dislocations, and then seizures that are patients in status epilepticus. There's a downstream brain effects or injury to neurons as well.
Okay, and is there a particular length of status epilepticus where that risk kind of skyrockets of brain injury, or is there a particular, I guess, time? Because some status epilepticus may last for just 5 minutes or something, and then rescue medication is administered and the seizure stops. Others may go for half an hour. Others can go for even over an hour.
Right.
Are there particular time frames that are kind of where you're more likely to then develop brain injury, or is it just the longer it goes, the higher the risk?
So seizures, the longer you let it go, the longer you let status go, the harder it is to treat. Seizures, just like this is much said of stroke, but it's less so for seizures, but it is true both. Time is brain, so the longer seizures are ongoing, the less you just have to nip this in the bud. So early status is within that first 5 minutes, where benzodiazepines like Ativan and other benzos can play an effect. But the longer that, so once the patient's established status, and then unfortunately refractory status, and in some rare cases super refractory status, that's a time period where there's this high mortality, morbidity. The longer the seizures are going on, even medications like benzodiazepines would less likely work. This is believed to be just less GABA receptors for these medications to work on. So again, the longer the seizures are ongoing, the more neuronal toxicity from I guess I'm not going to go into the buildup of extracellular calcium and other excitatory factors.
Sure. And how common is it for there to be brain injury from epilepsy surgery, like from stroke or brain bleeds or anything along those lines?
From epilepsy surgery?
From resective surgery.
I don't know. I don't have that information, Russ.
Sure.
I don't know the numbers on that.
Yeah, I mean, from everything I've read, it's a very low risk of stroke or infection or bleeding.
You mean complications from having the brain surgery?
Exactly.
So.
Yeah.
Yeah, I agree. I think from my understanding, this is a very patients that are selected for epilepsy surgery have been highly selected and felt to be highly successful in that. If it's high risk or if it's an area of the brain where this is felt to be a low likelihood of success, it would not be offered.
Okay. And in terms of falls, people who have frequent tonic-clonic or atonic or even tonic seizures that cause sudden falls, do you have any general guidelines as to when someone should wear a helmet, or is that really kind of just an individualized decision as to whether someone is willing to put up with the hassle or the discomfort of wearing a helmet, or whether they emphasize are focused more on the risk prevention from falls?
I think head protection, such as helmets or other protective gear, if this patient has no history of repeated recurrent seizures resulting in falls, I do recommend that they have a helmet. This is low risk. Yes, it is inconvenient, but for patients where with Lennox-Gastaut syndrome or other, and there's the ambulatory having a fall, there's tremendous risk to that, including risk of bleeding and other skeletal injuries. So I do make that recommendation for them.
Okay, great. And are there a fair variety of effective helmets out there for people to choose from, so that they can maybe find something that works for them as far as appearance and comfort?
They probably are such. I'm not familiar with the different types of helmets.
Yeah. Okay.
I'm at a loss.
All right, that's fine. Have you ever worked with or read about a patient who developed epilepsy, then acquired a brain injury, which then led to essentially a second case of epilepsy on top of the first? Is that something that happens? And if so, what kind of challenges does that pose from a diagnostic and treatment perspective?
I have several patients like that. I have a very nice elderly lady who she has idiopathic generalized epilepsy. She has juvenile myoclonic seizures, and but unfortunately also had a ruptured aneurysm in her left temporal area, and then subsequently developed focal seizures. When she first presented to me, we didn't know she had generalized epilepsy, as well as always thought that her seizures were a result of the aneurysm. So she came to me on a few older generation seizure medications. I think it was Dilantin, and she's also on Tegretol. And she had improvement, but still had breakthrough seizures, and for many years was on the same regimen, and was suffering from osteoporosis. And I think this is what why her neurologist sent her to see me. She was nervous about changing, and really hasn't tried on very many medications. So because of the frequency of her events, I ended up admitting her to the epilepsy monitoring unit, and within that first 24 hours figured out, okay, well, she has two types of epilepsy, a type that was just never diagnosed in the past, which is kind of shocking, because I think she did have EEGs prior to being seen here by our epilepsy team. But anyway, so until that moment in time, when we did the long-term EEG on her, because the history of her seizure semiology wasn't very clear, and but once we realized that she actually has two types of seizures, and unfortunately one of the medications that she's on was exacerbating one type of her seizures, after we adjusted some medications, switched her to different newer generation seizure medications, she's been doing fairly well with hardly a breakthrough seizure. So not identifying the correct seizure classification can lead to adverse effects and wrong medication choices and suboptimal care.
Right. So I imagine there's not necessarily common, but that is something that can happen where, someone has been treated for a genetic generalized epilepsy, and then has some sort of injury that maybe at the time they didn't even recognize the injury, and develops a second type of epilepsy on top of that original one, or vice versa. They develop an epilepsy that's clearly identified, or the cause is known, and it's a adult onset epilepsy, but they had some sort of injury or infection or something earlier in life, and it was missed at the time. And so I guess the bottom line is that if someone is having kind of two different types of seizure patterns, or seemingly two different types of epilepsy on top of each other, seeing an epileptologist to really get at that, whether there might be two types of epilepsy going on, can be really helpful.
It really does. I think this case for me illustrates how important it is to arrive at a appropriate diagnosis, and not to, because things are obvious, like she obviously had a ruptured aneurysm and obviously has residual neurologic deficits from that injury, and if we just had continued that stream of thinking, would have missed the bigger picture of that she actually has two separate entities going on, unfortunately for her.
Yeah.
So sometimes things that seem obvious, it does warrant a deeper investigation.
Sure. Okay. So depending on the severity of the brain injury, rehabilitation may be needed to help restore function and also teach compensatory strategies. So can you talk about the process of rehabilitation, some of the keys to success, and then the respective roles of the many different healthcare providers that can be involved?
Okay. So after somebody has sustained an injury, whether it's mild or moderate or severe, the rehab phase will begin once that person has been stabilized and awake and able to participate, because this takes active engagement from the patient. So this rehabilitation phase of treatment involves, as you said, is to restore function and to teach compensatory strategies. So this would involve a multidisciplinary team, including physiatrists, physical therapists, occupational therapists, speech therapists, and other specialists like dietitians, nutritionists, to help this patient return back to their as much as their normal baseline as much as possible to their the maximum level of function, such as their ADLs, activities of daily living.
Right.
This is a team approach, involving also family members and often psychiatrists and counselors, as this is a long journey, and oftentimes despair and depression can set in, because after this injury has happened, oftentimes this person is not has insight and knows that they aren't the same again, and coming to terms with that is difficult. So consultation with psychiatrists, counselors, social workers, it's very important in the management of traumatic brain injury patients with or without post-traumatic epilepsy.
Mm-hmm. And have you noticed that insurance coverage often dictates how long for how long that person can get rehabilitation services, and that sometimes patients don't get as much as they need or as much as they could benefit from because insurance companies decide, you've had enough, and just decide to stop covering it. Does that happen a fair amount?
Yeah, I do.
Okay.
I've just from word of mouth from my patients as well as in discussion with physiatry colleagues. I think this insurance plays and managed care, plays a big role into every facet of medical care. But same with rehabilitation. So I had a patient who had a shoulder dislocation. He has repeated shoulder dislocations from his epilepsy. Every single time he has a seizure, he falls, he dislocates his arm, and to the point where they can't really fix it anymore. Mm-hmm. But rehab helps, and he's only able to get a certain number of weeks, and then if it's too much, then he'll have to wait until next fiscal year, or I'm not really clear on the specifics of how much different insurance companies cover, but it is limited. Yeah.
Traumatic brain injury is often referred to as the signature injury of the most recent wars and conflicts, and this often includes epilepsy. So in addition, post-traumatic stress disorder is common in veterans, and that may lead to psychogenic non-epileptic seizures. So can you talk about post-traumatic epilepsy and psychogenic non-epileptic seizures in veterans and discuss some resources available that might help them to obtain the services and supports they need?
Yes, I'll try. So I think I'll start with talking about what, for the audience, what the psychogenic non-epileptic seizures are.
Sure.
So psychogenic non-epileptic seizures, PNES, or actually, I guess the other term for that is psychogenic non-epileptic events, whenever I give counseling in the epilepsy monitoring unit after I've completed the EEG investigation and found psychogenic non-epileptic seizures, I tend to skirt away from saying the word seizure at the end of this phrase because it's difficult to tell patients that and they're hearing the word. So I actually tend to say psychogenic non-epileptic spells just to lessen the confusion, because as soon as that patient goes into the ER saying they have psychogenic non-epileptic seizures, unfortunately, the only part that some doctors hear is the word seizure, and then ongoing, they put back on the same treatment that we just try to get them off.
Sure.
So anyway, these psychogenic non-epileptic events are different. So while epileptic seizures are caused by a surge of abnormal electrical activity in the brain, the difference between this and psychogenic events is that psychogenic events are not associated with this abnormal electrical event in the brain. Clinically, though, I would say this is difficult to distinguish between the two for many people, including caregivers and some providers, and I think even patients themselves, which can feel very similar to actual seizures. Unlike epileptic seizures, though, psychogenic non-epileptic seizures are caused. It's believed to be caused by psychological distress manifesting as physical symptoms. Now, some people have both. So I think the prevalence of comorbid epilepsy and psychogenic non-epileptic spells is 2 to 15%, depending. I think by some estimates.
Sounds about right.
Yeah, so it's not like very high, but it's high enough to make it very difficult to treat when patients have both types and both entities in the same person. Anyway, so psychogenic non-epileptic events are not caused by abnormal surges of electricity. So medications, anti-epileptic medications used to address through different brain channels like sodium channels, calcium channels, they don't necessarily work for psychogenic events, for non-epileptic events, but may have adverse effects. These medications categorically can worsen mood disorder like depression and anxiety, which is this is believed to be the underlying etiology for psychogenic events. So taking anti-epileptic medications not only does not help, but can worsen the underlying problem. So this is not good. Anyway, so one of the so patients, so veterans, that's what we're talking about, having it would stand to reason that they have had endured post-traumatic stress from just witnessing the things that they witness, whether it's in combat or other arenas. And so I would expect that there is a higher rate of PTSD in this group of people. And so PTSD is a significant positive predictive factor for psychogenic seizures, especially in the veteran population. Actually, there are some studies looking at psychogenic seizures in veterans and found that these individuals have a greater degree of like Axis 1 diagnoses with, I think I butchered that. So these individuals with psychogenic seizures are found to have more psychopathology than those that are found to have epileptic seizures. So in particular, so veterans that are diagnosed with psychogenic seizures, so they're more likely to have PTSD than veterans diagnosed with epileptic seizures. I think, maybe that sounds a little bit better.
Right. And then presumably just general neurologists who might be working in the VA might be less familiar with psychogenic non-epileptic seizures than like an epileptologist. So is there well, at least I'm aware of a couple of resources that veterans can access if they are in that situation and they feel like they're maybe not getting the right diagnosis, and that there are several VA epilepsy centers of
right.
excellence. I think the closest one is in Madison, Wisconsin. But there's also something called the Veterans Choice Program that can actually allow veterans to see a specialist outside of the VA if they can demonstrate that it's necessary. So have you ever had veterans referred to from a VA or have you heard of that happening because they may be unclear on that diagnosis?
Yeah, so I personally have not had patients referred from the VA, but so I'm not too familiar with the VA system. Sure. But in review, I think this is probably something I found on the Epilepsy Foundation website. They or linked to the what you just mentioned, the VA Epilepsy Centers of Excellence. It seems to be pretty wide in scope across multiple states. I think there are 16 centers and has capability for telemedicine. I don't know how effective this is, and I'm not sure whether these are mainly like what levels of epilepsy, whether any of these are comprehensive epilepsy centers or right. Whether they're level 3 centers. I'm not really familiar with that information.
Sure. Okay. And I'm guessing that because the physical trauma that can lead to traumatic brain injury can also include psychological trauma. So, for example, in a case of violence, if someone was in a situation where there was domestic abuse or was the victim of a violent crime or a car accident, those can be both psychologically traumatizing and can cause physical trauma to the brain. So is there a higher incidence of that comorbid psychogenic non-epileptic seizures in people with post-traumatic epilepsy than in the general epilepsy population?
I don't have
probably not good
really
data on that.
For that. Yeah, I'm not sure that there is. Do you know, Russ?
It's one of those things that seems to make sense I've talked with clients before who have both had they've been in a situation with earlier in life with an abusive family member, for example, and they sustained both psychological trauma from that relationship and also physical abuse that included a blow to the head and a brain injury. And so I would just assume that that person may be at risk for both non-epileptic seizures and epilepsy, and as a result of that combination.
I agree.
Of factors.
I think anecdotally, yes, it's not uncommon that after whether it's a post-traumatic seizure, so immediately after somebody has had some kind of injury, they had a seizure, and later on there's development of paroxysms that not uncommonly are found to be non-epileptic in the future. Mm-hmm. So I think anecdotally, many of us do see that, but I don't have any statistics on like how often this occurs. I'm not sure that this is has been studied.
Yeah, probably not. Yeah. So non-epileptic seizures. There's a lot could certainly benefit from a lot more research to find out the different causes and the best, most effective treatments and that sort of thing. So and because we want to limit harm to patients, whether it's if they don't have epileptic seizures, continuing to treat them with more and more epileptic drugs, anti-epileptic drugs, would just lead to, as we just had talked about, more adverse effects than good. Right. Unfortunately, patients with psychogenic non-epileptic events constitute a high proportion of the community. I think in some estimates, up to 40% of patients admitted to an epilepsy monitoring unit are found to have psychogenic events. Right. So this is
a pretty staggering number.
Yeah. Okay, so before we open it up for questions, do you have any closing thoughts on this topic that you'd like to share?
I don't, apart from saying this is a very difficult topic.
Yeah.
Very complicated topic. Yeah.
Right. And my computer just went to sleep, so give me a second here before I... there we go. Okay, so I'm going to actually unmute the lines, and I do remind people before I do this, if you're not asking a question or making a comment, please do keep your line muted, because that will just eliminate any background noise. Okay, so just a second here.
The conference is now in conversation mode.
Okay, and before we have any questions, I just wanted to, we have Kathy from the Brain Injury Association of Michigan. Are you still on the line, Kathy?
I am still here.
Yeah, did you have any thoughts you wanted to, yeah, thanks. Did you have any thoughts that you wanted to share based on some of the things we discussed, or if not, would you be willing to talk just briefly about some of the services that Brain Injury Association of Michigan offers?
I can talk a little bit about the Brain Injury Association.
Sure.
I do not necessarily have any thoughts or comments. You know, I guess I was here to learn, just like everybody else,
sure,
more about epilepsy. So, but just a little bit about the Brain Injury Association. Well, first of all, we're part of the Brain Injury Association of America. So there's several brain injury associations across the country. But we're a nonprofit. We cover the whole state of Michigan. We're not like a government agency or anything. So we do fundraising events, and membership helps with our funding, I guess.
Mm-hmm.
But the main thing that we do for people with brain injury is that we have support groups throughout the state. We also offer educational opportunities. So our big fall conference is coming up in September. So right now we're in the middle of registration for that. In fact, I believe today was the deadline for the early bird rates, they call it.
Right.
But the one thing for any brain injury survivors or family members, the early bird rates do not apply. We have no deadline for those people to get signed up. We don't change the rates at all.
Okay.
Professionals, if there's anybody interested in signing up, they should get signed up today, I'm afraid. But it's the largest conference in the country in the brain injury field. It's September 12th and 13th, and we usually have at least 1,200 to 1,500 people attending each day. So, but those are it is pretty big. Maybe about 120 exhibitors there. We do a lot of work with prevention, trying, this past year we've given away, I'm not even sure how many bicycle helmets to kids in poor communities. So those are the main things I can think of. There's so much more to the Brain Injury Association. Feel free to visit the website or give me a call with any questions, I guess.
Sure. And what is the website again?
Sure. It's www. And then it'll be the initials for Brain Injury Association, BIAMI.org.
Okay, great. Thank you. Thank you for sharing. So does anyone have any questions for Dr. Phillips?
Hi, this is Maggie.
Hi. Go ahead.
I actually, and I apologize if I get a little long-winded. This is the first call I've been on, the first conference call. So the first question I have is, can you tell me a little bit about rehabilitation after epilepsy surgery? Like, is it similar to that of a brain injury, or would there be like different type of therapies they would look at?
Yes, actually. So, like any other brain injury, I believe this would be tailored to the individual needs, depending on which area of the brain had been resected and what was the extent of the resection. So if this is an area of the brain that involved language function, for example, that would be there would be a prominent role for speech therapy. Or if this is so anyway, I think this would again be a multidisciplinary approach, but would be tailored to the individual needs of that patient, depending on what type of surgery and where this occurred.
And doesn't just to interrupt for a second, doesn't the whole pre-surgical evaluation process, one of the key points or goals of that is to minimize the need for any kind of rehabilitation and minimize any kind of functional deficits resulting from the surgery, so that you're avoiding areas or avoiding taking out areas that it controls speech or movement or vision or things like that. So I think in general we'll try to minimize that. And overall, would you say that in general, like what is there an average amount of time or recovery time or time spent on rehabilitation after, let's say, just a temporal lobectomy? Is there a typical recovery time after that, or is it really more dependent on the individual?
I think this is depending on the individual.
Sure.
But like you said, it's benefits for having this procedure. If there is any indication that after getting resection and there is deemed to be a higher risk or more disability from that procedure, the surgery would not have been offered. In terms of how long after a procedure has been done for rehabilitation, I don't know that. I think this question might probably be better addressed to either neurosurgery or to physiatry.
Okay, no problem. I do have another question, though.
Sure.
And this one relates to the psychogenic episodes you were talking about with, for example, the PTSD and the veterans. So I have a slightly different case here. I have a child who also deals with autism along with the epilepsy. And it seems that his some of the concerns we have with his autism and his mood and his behavior are definitely affected by the medication he takes for the seizures. And each one kind of affects him differently. So that's kind of on that surgical path right now. But would it work the same kind of as the PTSD and as it would with like different kind of mental disorders? So I hear you. I mean, it sounds like when you have two different issues going on with his autism and trying to get care for the seizures, and you're having adverse effects that's what you're saying, right? There's adverse effects from the medication to treat his seizure for his autism. Yeah, that's very difficult. But there are a lot of medications. There are 30 different anti-epileptic medications out there. Unfortunately, finding the right recipe may take some trial and error. So hopefully he can be put on a regimen that causes less side effects for him. And you said he's going down the surgical path right now for a pre-surgical evaluation? Yeah, we're actually very close to a presentation to the surgery team. We've done quite a bit of, the pre-testing. Yeah. So actually today he had a full neuropsychological exam.
That's great. This is, I think anybody who
so seizure care is twofold. One is to have no seizures, but the second, and just as importantly, the second goal is to have no side effects from the treatment. I mean, it's not good care when somebody suffers more side effects from their treatment for the seizure than the actual seizures. So if he's either not tolerating the medication or it's not treating his seizures, it's not controlling his seizures, then I think having that testing to see whether or not he's a candidate is a great idea. This would be a standard of care. So hopefully he's successful in that. Now, your question was about psychogenic non-epileptic events.
Yeah, like for example, the anxiety or the mood, fluctuations that could go along with the autism. Could those be heightened or affected by the seizures or the medications, I guess?
Yeah. So could be both. But yeah, when behaviors are happening and we're not sure whether or not these behaviors are because of seizure or medication side effects or something different or mood related from, like you said, anxiety or nervousness. Sometimes even the patient themselves don't have any control over. When there's a question of or uncertainty as to what the nature of this behavioral change is, it's very important to get more definitive information so that somebody is not undertreated or overtreated. And the only way to really know for sure is with EEG. So likely that he would have that as part of his pre-surgical evaluation to make sure that every single type of seizure or every single type of behavioral change, whether some people have more than one type of seizure, and they look very different. Some people, I actually have one patient who has 4 types of seizures, and she has pet names for every single one of them. And so as part of his surgical evaluation, his epileptologist would want to make sure to have captured every single one of the different types of behaviors that he has to ensure that they are getting the correct epileptogenic zone, so they're not attacking the wrong area, and that it's thorough and complete. And in this case, if there's a question of possibly some anxiety or other psychogenic reasons for his events, that this has been ruled out. So even the patients we know clearly has epilepsy, we want to make sure when they have a new or additional new type of behavioral change that this too is either seizure. If it's not, then it should be put on the right path of treatment and not to be given additional medications with no perceived benefit.
Okay, that's wonderful. Thank you. I appreciate your time.
You're so welcome. Good luck.
Okay. Other questions?
My name is Kim, and I have a question, and I'm trying to figure out how to word this. Can you hear me?
Sure. Yeah.
Hi. All right, my name is Kim. I'm 45 now, but when I was, 25, because I was 27 when I started having seizures. Okay, when I was 25 years old, I got assaulted on cement with a 4-year-old in my arms. And I sustained, they called it a closed head injury in the hospital, but I turned out fine. But then 2 years later, I came down with a whole bunch of seizures, but I didn't have really an MRI or anything, I think, till 10 years later, because nobody knew what was wrong. So 10 years later, I had the MRI, and it showed the 6 different types of episodes, and they said I had PNES. My question is, would enough time have been passed to see the whole picture, or should I have another MRI to see if epilepsy has set in?
So MRIs can be completely normal in patients that have epilepsy. It's important to look because I would say between EEG and an MRI, to have thorough epilepsy workup, one should have both. The MRI is to make sure to check for a structural lesion, a structural abnormality that can cause seizure or can increase a risk of seizure. Whereas an EEG looks at the electricity in the brain to look for, again, a predisposition for having recurrent seizures without something causing it. And both are important as a standard seizure workup. an MRI would not definitely show a seizure. Actually, MRI would probably be normal in most individuals who have seizures.
Well, I had an EEG. I'm sorry. I don't know if I said I had an EEG done.
Okay, I got it.
I'm sorry. There was 6 different episodes that they caught. But they didn't say I had epilepsy. I'm just saying, would I be free from epilepsy by now, or is it something I should look into?
So that's a great question, and I should have mentioned this when I was talking about the psychogenic. Yeah. So now, if you had a long-term EEG, and this EEG showed, captured all the events that you're having, that you've been suffering from, and a qualified person reviewing this EEG saw that there was absolutely no EEG change, and more than that, that your episodes, based on how it looks clinically, matched up with the EEG, would definitely not be epileptic in nature, then I think that's satisfactory. Having an EEG, so I'm actually on epilepsy monitoring unit call this week, so every day I round on patients here with seizure. Now, sometimes as soon as I admit the patient, like actually just very recently, I had a patient who had lots of events, and some of these sound not so compelling for seizure, but that could not be ruled out, so we did a study. After the first hour of her admission on Monday morning, we already captured 3 events. Now, if I just had let her go as she had wanted, we would not have captured what we did later on, because in fact she had both. So some people have both types of events. They have events that are psychogenic in nature, that are not epileptic, and but also epileptic events on top of that too. And the treatment can be very difficult. So it's important to check out, if this person has, if you have multiple different types of events, to make sure that these have been addressed. It sounds like you had 6 events during this time that you admitted, and the workup was thorough, I would say, based on what you said, right? So
yeah, I mean, I only had to stay one night because, like, right away when they did the eye flashing test, it brought him out bad right away. And the next day, when I couldn't even get up off the floor, they captured that one too.
Mm-hmm. So I think if everything that you had been captured there, I think you can. I think there is reassurance that these events are non-epileptic, so you can be put on the right path of treatment instead of continuing in the same process that is not helping, but rather leading to more side effects. Now, in addition to having events on the EEG that's captured, the majority of this EEG is what we call an interictal recording. This is the period of time when someone's not having an event, and that is also just as important to see whether somebody has a risk of seizure, because sometimes patients, their events may not be epileptic, but I'm seeing on the EEG that they do have a risk for seizure. So if your neurologist or if your epileptologist told you that your events are not seizures and you did not have abnormal discharges on your EEG, the so-called interictal epileptiform discharges, then I think that's reassuring that that there's no epilepsy going on right now. Now, if your events change or if you have new events, that's not to say that they are definitely also not seizures. So having a normal EEG, even if it's an epilepsy monitoring unit stay, one period in time doesn't mean that for lifelong you are vaccinated against a future seizure, because things happen. Trauma can occur, like we just talked about. Hopefully not, but maybe a stroke may occur in the future. And then this, if clinical symptoms change, it warrants further investigation. Okay.
So you think maybe I should try another EEG? I've been having some different symptoms. So.
Yeah. If your symptoms have changed and they are new spells, so having a EEG is non-invasive. For the most part, no one has any side effects from that if you've tolerated having an epilepsy monitoring unit. This is the most definitive test for differentiating between psychogenic non-epileptic events and epileptic events, and that's the difference in treatment is like 180. So if you have new events, yes, the EEG is very important in differentiating between these two. I'm sorry if I misspoke. It's been a long day. So yeah, if you're not sure and you feel like your events have changed or you have new types of episodes, talk to your epileptologist about it and try to figure and see whether or not, based on what you describe, whether this warrants having another test. Now, that said, I never make my patients do additional testing unless it changes my management or that it means something. I don't do testing for the sake of testing.
Right. Yeah, I think that's the key thing is if your episodes have changed, if you're having the same types of symptoms with your episodes, then it seems unlikely that would suddenly be epilepsy and not non-epileptic seizures. But if there is some change, then that could potentially indicate that something else is going on and might warrant further investigation. Is in relation to Kim's question, is there is no period where you're officially in the clear after a traumatic brain injury, right? It's not like if you get to 20 years and you don't develop epilepsy that now suddenly you're not going to get epilepsy, right?
I think there's never, because none of us have a crystal ball.
Sure.
It's never like never ever. But the longer one is farther from the initial insult, the brain injury that occurred, the less likely this person will develop post-traumatic epilepsy.
Right.
So it becomes more reassuring over time. But does that risk ever go down to zero, I think is the question. I think probably not.
Yeah. Okay. Other questions? We have just a few more minutes, about 5 more minutes left. Anyone else have a question?
You're so welcome.
All right. Okay. Well, thank you so much, Dr. Phillips, for covering, as you've said, a very, very difficult and complicated topic.
I really enjoyed this discussion. Yeah. I learned a lot from reading about things. I'm not as well versed in this topic as much as I would like to be.
Right, and I think there's still so much to learn about it. I mean, obviously the brain is so complicated, and there's a lot of research going on, and I think that goal is to be able to identify people who've had some sort of brain injury and then intervene to reduce the risk of epilepsy. And
like you said, this holy grail to stop epileptogenesis within this window of time that's available.
Yeah, and I think we're going to get there at some point or get closer to that. But until then, it's all about understanding it and managing the two conditions. So again, thanks so much for your time, and thank you everyone else for joining us. If you have further questions about epilepsy, certainly, or this topic, certainly feel free to give us a call at 1-800-377-6226 or visit our website at epilepsymichigan.org. Our next Learn and Share conference call is on September 4th from noon to 1:30 p.m., and the topic is epilepsy and emotional well-being. And we have two mental health professionals from Michigan Medicine who will be our guest speakers. So hopefully, and I think that's something that everyone could benefit from, because everyone with epilepsy is at higher risk for depression and anxiety, and I think everyone, even in the absence of depression or anxiety, can benefit from investing in emotional well-being. So again, thank you, Dr. Phillips, and thanks everyone for participating, and we'll talk to you soon.
Thanks so much. Bye.
Thank you.